All right, what's going on, everyone? I'm going to do the second installment here for the lecture. It's going to be focusing on the pediatric population. Um, so let's get into it. Pediatric is basically just going to be anybody who's under the age of 18. So just giant key points to consider here. So instead of our infants, anybody within under a year, they will tend to receive 10 mils per kilo. Our pediatric population is going to be getting a 20. So if they're hypovolemic, 20 mils per kilo as a bolus. If we're in hypovolemic shock, about 40, 60 ml per kilo, and our sepsis, which I don't believe any tests are going to ask about our sepsis or maybe hypovolemic. But just understand you may have to give a little bit more of fluids. Special consideration for any of our shock. If we have any cardiogenic shock, you're going to want to do a little bit less. Probably opt in for a 10 mil per kilo. Just due to if we're in cardiogenic shock, just understand that we have a shit pump. So just a little bit less workload. There's no reason to influx it. It's just going to shut down even farther. Big key points here is our injury is going to tend to be more volatile towards the child, and they are at higher risk for injury. And we'll get into there in a second. We just have some certifications or continuing education for the pediatric population. Don't worry about them, not important. So only 85% of our ped patients require nothing more than BLS care, so be super aggressive with your treatments. If you have any respiratory distress, just slap the BVM or non-rebreather on them. They'll tend to perk up pretty well. Just because of their organs are very fresh, there's no disease processes. We don't have anything to deal with like hypertension, no diabetes, liver cirrhosis, no cardiac history, hopefully not. So there's not going to be no pharmacological alternons for how your pharmacodynamics are going to go through. So giving a medication, for instance, they'll be very responsive. Neonates are going to be birth to 1 month, just like we followed on our last video here. Now we have our infants, 1 to 5 months. So things to look out for is kind of their head. You can kind of see, if this is the patient's head. Their fontanelle is not fully developed, so it can be kind of squishy, indented inward, kind of showing dehydration. Or you may have something like a bulging. You'll see with ICP or hydrocephalus. So these are pretty telltale signs of the patient's conditioning. Be aware for SIDS, vomiting, dehydration. These are pretty big in the hypovolemic stages. Child abuse and meningitis. So we have our Koenig's and our Budzinski sign. And of course, our increased ICP, and then fever, nausea, decreased eating with meningitis. Very easy to look at and do an assessment. So this kind of like the milestones almost. You're be able to stand and walk. Here are some of the common illnesses you're going to see just in this population. Not the biggest thing to worry about. Just understand when you have these things in front of you, just know how to correctly assess and treat the patient for the best outcome. As we get into the ages of 1 to 3, they're going to be moving a little bit more. Preschoolers as well, they're going to be gaining gross motor movement. The best thing I could probably say is grab a badge buddy off Amazon if you need the milestones of life, or just memorize it if you can. Good luck. Here are some of the differences for children. So that head's going to be proportionally larger. Less blood volume. So if you remember Tyler doing the bathtub for adults, kids tend to be a little small cup here. Higher respiratory rates just because of that increased metabolic demand for glycolysis. So that's going to be kind of like anaerobic metabolism. They're going to need more O2 because they're going to be burning everything off because of their immature hypothalamus. They're unable to shiver at younger ages. So their main source of conducting a increased temperature, so they don't go hypothermic. It's just going to be burning off all this ATP. So they're going to be using it by the respiratory rate. Here we go. Temperature control is immature. Dehydrate easily. Yeah. Here's a child. So what we can do here, any child that we lay prone, if we have to give ventilatory support, you can see as the child just lays supine, his airway might actually become obstructed. So we'll just pad the void. This will kind of give us that sniffing position and give us the best outcome on getting an open airway. Big characteristics on their A&P and anatomy. His tongue's going to be proportionally larger. Their trachea is going to be narrow, more pliable, easy for obstruction. Pediatrics are abdominal breathers, as we know. And the spleen and liver is more exposed and larger in size. So this is going to be extremely prevalent in any abdominal trauma or multi-system trauma, that our spleen and liver can be easily lacerated. So if they fall from a tree, that's something we have to look out for, any intra-abdominal bleeding. So we have our colon sign, so that will be our preumbilical right here. And then we also have our Turner sign, which is going to be that retroperitoneal ecchymosis. It is larger. We already know this. Pay attention to the fontanelles. They're not going to be fused yet until 4 months, 4 to 18 months, excuse me. So if you do have some different signs, you may have a pulsation. Things like we see in meningitis especially, and or ICP, you may have a pulsating with bulging. And the more ICP you have, it'll kind of tighten up, become a little bit more firm, and you'll decrease in pulsations. Dehydration will have the opposite. We'll just have a sunken in. So the more pediatric patients you see, the more you'll kind of get the idea of what looks normal and what looks sunken. Manage the airway, we'll do a sniffing position. Airway, they're going to be more narrow. The smallest portion of the pediatric airway is going to be the cricoid cartilage. They are nose breathers and abdominal breathers. Tongue takes up more space. We already know this. Larynx is going to be more superior and anterior. C3, 4, 5, keep the diaphragm alive. Just remember that. Here we go. And the epiglottis is going to be very floppy. Chest and lungs, they're going to tire easily just because of the immature intercostal muscles, and just for them being one shot when they come out the gate. They're not going to be able to compensate for too long, but they'll compensate very well. Soft and pliable ribs, less protection of the organs, no duh. They are diaphragmatic breathers, prone to gastric distension just like adults. Just remember, smaller abdominal cavity, bigger chance for distension, or just less volume of air to get that distension prevalent. Pretty high in trauma. Pulmonary contusions are very common with any trunk trauma. Just keep an eye on that. Look out for your pneumos, thin chest wall, easily transmitted breath sounds. The abdominal, like we talked about, our liver and spleen are proportionally larger, so very susceptible to laceration. Extremities, here we have our rule by nines. Best way I think of it this way, so if you just take the entire arm, just kind of ignore the 4.5 because you have your anterior and posterior. 9, so if you're like a monkey, you grab your two hands and bump them against your chest, and you do your whole trunk here. 9 plus 9 equals 18. Just remember down here, 18 as well for both, front and back. And you got your head for 9. That's going to be for the adult patient. Pediatrics, it gets a little larger. So you'll do 9 plus 9, beat your chest, you get 18. 14, I don't know, just remember it. It's kind of difficult. Respiratory system, because of that increased metabolic demand, smaller O2 reserves. Any changes within their respiratory rate to where they're not going to be able to get enough oxygen, they are at very high risk for developing hypoxia, so they will require a lot of O2, even in small, just low nasal flaring situations. Cardiovascular system. Hypertension is going to be a very late form of shock. Like I said, these these pediatric patients are really well with compensating, but once they start to lose that blood pressure, they will tank tremendously. Yeah, nervous system should be good. Any metabolic differences, just keep them warm. Be nice to them. Lack ability to sugar. Here we have our pediatric assessment triangle. We have our appearance, work of breathing, and circulation of skin. You check these three things no matter what, whenever you can. Without one of these, the triangle will fall. So just assess their appearance, skin sign, color, condition, stuff like that. How are they breathing? How do they look? And then you can look at work breathing. Is there any retractions? Any acrocyanosis? Circulation, skin. Check your cap refill. Check some vitals. You can go from there to their paddle or modeling. If you guys want to take a second, just kind of pause the video, take a look at this. We have our normal blood pressure readings. Here's our little formula. We can do 90 plus 2 times your age, and you'll kind of get your average systolic, what you're going to be looking for. Respiratory rate, really you won't see anything until about 3 years of age. You'll kind of see a sudden decrease, at least around 30 and under, and it kind of generally goes down slowly. And then we got our beats per minute. This one's pretty important.
114.
Transfer priority. We have our GCS.
114.
This is something we already know.
Oh, we're here, so.
Basic airway management.
Don't do that 114.
This is something we already know as well. With any of the test questions where they're asking what you should do, just do least invasive or the most simple, and then work your way up to, depending on the criticality of the situation. But you should be good on doing basic airway maneuvers first, and then moving on to, let's say, an ET or crike. Manual positioning. Yeah, be careful on hyperextending their neck. You will snap that shit if you're acting like an asshole on scene. Foreign body airway obstruction. So if we have a partial or mild, as the textbook calls it, you'll have a cough, cry, hoarse voice, airway exchange, and stridor. This is where only partially of your airway is obstructed. But in our complete, you'll have no airway exchange, and the patient will tend to go limp very quickly. Treatment for our partial, we're just going to position of comfort. If it's not in the way and they're able to get airway exchange, just take a nice priority 2 over to the hospital. But if we have this severe airway exchange, they're quickly going to become hypoxic, unconscious, and then probably cardiac arrest. So intervene with abdominal thrusts. As soon as they go unresponsive, then we're going to initiate CPR and start our PALs. With our infants or anybody less than the age of 1, we're going to do the 5 back blows and then the 5 chest thrusts. And then after each time we do a cycle of these two, we'll check the mouth. Never do a blind finger sweep. And we'll just continue that. If they go pulseless and apneic, once again, we'll do CPR. Suction catheter sizes, I don't give a fuck about it. I'll probably just take the L if they ask me a question on that. Things to keep in mind. Yeah. There you go. Oh, be very careful on suctioning sometimes. Just because we have that vagus nerve, cranial nerve 10, on the hyoepiglottis, if you start banging, your suction cath down there and start irrigating the epiglottis, you can stimulate that nerve, so you will see some bradycardia. So be very careful of that. Oxygenation, anything above 94, we're good. Blow by if you need to. There's that stimulation. OPAs, you guys know how to measure this stuff. You go from the ear here up there, and then drop it in nice and easy. NPAs, we kind of already know the indications and contraindications on this. Just don't throw an NPA with any basilar skull fracture, any head trauma, anything like that. The younger children have enlarged endenoids, which is our lymphatic tissue, and pretty easily lacerated, so you can have some pretty profound bleeding within that airway. So not only do you have to manage an airway, you have to clear an airway too with suction. So that can be a very difficult process if you do end up actually lacerating the patient's airway. We got ventilation here. Things to importantly remember: don't ever hyperventilate. use capnography, proper mask. You want to get a good seal, attain chest rise until, squeeze the bag until you meet adequate bilateral equal chest rise. Provide 100% O2. Correct blood pressure to minimize gastric inflammation. We got our foreign body airway obstruction again. We already know these skills. Laryngeal scope, blade, McGill's, intubate around the obstruction if we need to, or if we are unable to, like on a call for ingested peanut butter, you can't get any visual cricothyrotomy. Getting our correct tube size. So we have our age plus 16 divided by 4, and then that will typically give you your tube size you need. Yeah. Here's our teeth measurements. I was trying to figure out ET tube sizes are really big. If you ever have a newborn, 3.0, if they're within, I believe, 2,000 to 3,000 grams, you're able to do a 3. Anything above 3,000 grams, go for a 4. Anything below 1,000 grams, go for a 2, or 2,000 grams. Yeah, just remember this. I think your MyMedic card should be able to tell you what tube size you're going to be using here. Indications, you need to intubate. Simple as that. You want to visualize the chest cords, the tube passing the cords, bilateral chest rise, capnography, and lack of phonocation. We have our dope mnemonic here for possible deterioration with an intubated patient, so look for displacement, obstruction, pneumo, and equipment failure. RSI, I think we should be good on. So, yeah. Nasogastric intubation, actual cringe. I'm passing that. Circulation. 2 problems leading to cardiac pulmonary arrest in Peds is shock and a respiratory failure. Definitely respiratory failure, and I guess definitely shock too. We have our IO access. So the things we can use is epi, atropine, dopamine, lidocaine, sodium bicarb, and dopamine. If we can't get a peripheral IV access, this is something we're going to opt into. So right now you can see that they are in the typical tuberosity, anterior medial, about 1 to 2 centimeters over. It's going to be our goal there. Just do not drop one of these in here if you have a fracture within the bone anywhere, or if we have any degeneratable, like osteoarthritis, any diseases that may affect the bone. Fluid therapy, hypovolemic, so now we have our 20 mils per kilo. Repeat as needed. If we are in septic shock, you're going to be doing the 60 to 80. This is a very, very important little part right here. These are going to be all our drugs that we're going to be able to push on a pediatric patient and the correct dosagings. So epi, very important one, 0.01 milligrams per kilo in our cardiac arrest. Go ahead and pause the video, try and memorize all this. This can be very important stuff. If not, you do have your MyMedic cards to refer to. Electrical therapy is going to be 2 to 4 joules per kilo. You have the 2-4-6-8 method on how you will bump up your shots. All right, we'll stop here. Let you take a quick break. If there's anything you need to go over that I kind of crossed over, or just look at the notes, just kind of read over everything, feel free to do so. And we're going to start back up here with infections and just different disease processes and illnesses. So go ahead and take a break, and I'll see you.